On behalf of the Southeast PTTC, my name is Amber Jones, and it is my honor to introduce today's presentation. It is labeled One Counter, Many Solutions, Collaborative Approaches to Co-Dispensing Opioid Safety Kits in the Pharmacy Setting. And we are here with several amazing presenters, and they'll introduce themselves after we do the housekeeping. So a few housekeeping items. The first is the disclaimer acknowledgement. I am not going to read this to you. You will also get a copy of the slide deck post-webinar. I just wanted to highlight one of the places in bold that says the opinions expressed herein are the view of the authors and do not reflect the official position of DHHS and SAMHSA. And if you're not familiar with the PTTC network, we are a network of centers across the United States, and we are here to equip the prevention workforce by providing training and technical assistance. And we are just really glad you are here for today's presentation. Our center is specifically housed at Wake Forest University School of Med in the Southeast in Winston-Salem, North Carolina, and we are led by co-directors Woofson and Wagner. So one of the most asked questions, will we get a certificate? And the answer is absolutely. In order to receive your certificate, we please request that you fill out a very short survey at the end. It's also called the GIPRA. So if you hear GIPRA, it just means a short survey evaluation. And we really value your feedback. So please take a moment to fill that out, even if you don't need a certificate. It would really mean a lot to us. But after you fill out that survey, GIPRA, pause. And when you pause, the certificate will pop up. If you have any issues, we will make sure that we put our emails in the chat. Please feel free to reach out to us if you do have any issues. But again, just pause after you fill out that GIPRA, and then it'll say taking you to an external site. I promise that site is legit, and that's where your certificate is housed. So it is my honor to be able to introduce one of our teammates and colleagues on the Southeast PTTC, and that is Dr. Kate Egan. She is an associate professor, and she works on the Southeast PTTC project at Wake Forest University School of Medicine. And I'm going to hand it over to you, Dr. Egan. And then we are also joined by our colleagues at Community Impact North Carolina and two pharmacists that collaborative on the project that they'll be talking about today. And so before we get into the actual project, Dr. Egan is going to set the stage for us. So on to you, Dr. Egan.
Thank you, Amber. It's a pleasure to be here with everyone. I'm really excited for this presentation. So I am research faculty, and much of my research is in the space of overdose prevention services at pharmacies. So there are many roles that pharmacists can play in preventing opioid use disorder, as well as overdose. And so all these images are some snapshots of ways in which they can do that. So we have prescription drug monitoring programs, writing prescriptions for medication for opioid use disorder or dispensing them depending on your state, dispensing naloxone either by standing order or over the counter, providing lock boxes for medication, having medication disposal units at the pharmacy, providing mail-back pouches or deactivation products. So we'll talk about all of these things today. Well, not all of them, but some of them. So I wanted to put them out there for you. So these are different tools that pharmacists have at hand. Next slide, please. Why are pharmacists and pharmacies such an important avenue for overdose prevention? They can really improve access to these services, especially in places where there might not be a harm reduction coalition or a prevention services. So about 50% of the population live within 1 mile of the pharmacy, and almost all of us live within 10 miles. In terms of types of pharmacies, about 63% are chains in urban areas, and we have about 76% are independents in rural areas. So there are opportunities to have a little more control in the independent pharmacies to partner with and dispense these services. Next slide, please. So a little bit of the research. So I am kind of pitching my own research here. This has not been published yet, but this is an exciting finding that we have. So there are a handful of research studies that have examined medication disposal at pharmacies. And this will be the first one looking at national access to disposal boxes at pharmacies. So we have the map here, and the red dots are the pharmacies. So this was a sample. This is not a census of all the pharmacies. But among our sample, the reds are our no's, and the teal are the yeses that had disposal boxes. So you can see the dispersion across the sample in the United States. So we had a sample of about 1,000 pharmacies. So this was an increase from previous work I had done in North Carolina looking at disposal box access at pharmacies, but you can still see that it's only about 28% of pharmacies at the time that the study was conducted that had a disposal box, which I would say is probably the most common disposal service available. Some had deactivation pouches available as well, but not as common. Next slide, please. Thank you. And so there are quite a few studies on naloxone availability at pharmacies, and they're mostly all single state studies. So there are quite a few that have been done in North Carolina as well as different states. This was the first study to our knowledge that looked at nationwide access to naloxone at pharmacies, and it also included both the over-the-counter as well as prescription or standing order at the pharmacy. So what we're seeing over time across this research is that a growing number of pharmacies are having naloxone available the same day without a prescription. So about 62% of our sample did have naloxone available. So there's still gaps, though. That's important to note. Amber, can you hit the animation, please? Thank you. One finding concerned us in that about 20% of the pharmacies that said that they did not have naloxone available that day claimed that they required a prescription from a doctor, which is not true for their state policies. So there were gaps in ways that those pharmacists could be educated on their current state policies related to naloxone dispensing. And one more tap, please, for the slide. So, the cost. So we are noting that cost is decreasing of naloxone. So this is a cost without a prescription or filing with insurance. So we found that the average cost for over-the-counter naloxone was $52, which is a decrease, but it's still probably too expensive for people to buy out of pocket, right? So that's one challenge. Before we move on, I just wanted to note that we don't have studies that comprehensively examine the different services that pharmacists can offer. So I think that's one thing that's really exciting about the presentation today is that it's not just about naloxone, it's not just about disposal, it's about a comprehensive package that these pharmacists are providing. Next slide. I apologize, this is text heavy. So I saw the question. George, yes, the average cost for 52 was nasal for a 2-pack. So as part of that study, we followed up with the pharmacies, with a subsample of the pharmacists to do interviews to learn more about what are the barriers and facilitators of naloxone and medication disposal in their pharmacies. So that top bullet was the common finding from our sample was that individuals or pharmacists that did not have a disposal box thought that it was incredibly complex intervention and service to provide. There was mixed feelings about whether it'd be a place for people to divert and steal medications, and someone just thought it would be a trash can for some of their clients. But those that did have disposal boxes found them to be incredibly easy to maintain, especially if they were a corporate pharmacy. There was no cost to them. The independent pharmacies did share that there were issues with cost of maintenance. And then for the naloxone interviews, we found that naloxone dispensing does not always follow the state level policies. Pharmacists did perceive that naloxone costs too much for patients, which I saw heads nodding as well in this call. Pharmacists perceive that patients do not want naloxone because naloxone is stigmatized. And we did have a few pharmacists that held stigmatizing beliefs for patients who would request naloxone. That was not always the case, but there were a few. Next slide, please. And this is my last slide. I'm in implementation science. So one of the cool things that we have available with our frameworks is that there are evidence-based strategies that are used to address implementation barriers. So you can see there's a column on barriers. So we found that motivation of leadership is a barrier for disposal. And one of the strategies is to involve executive boards or identify and prepare champions to lead these efforts forward. Some perceive complex interventions. And so one idea is to build a learning collaborative, which might be what we're here for today. There's also the cost to pharmacy and our patients, so ways to access new funding. For naloxone, our barriers were knowledge of dispensing policies. So some strategies are to conduct ongoing training and develop and distribute educational materials. Cost to patients, so access new funding. And then for some, we have stigma pharmacists related to naloxone and those that might need it. So our strategies are to identify and prepare champions, obtain and use patient feedback, conduct ongoing training, and develop and distribute educational materials. So these are findings from my research, and I am thrilled to pass the baton to our speakers because they are actually talking about projects that use almost all, if not all, of these strategies identified here to serve their community. So thank you for your time.
Thank you, Dr. Egan, for setting the stage, and we are going to pass it off to our partners at Sync NC and two awesome pharmacists that they collaborated with.
Okay, thanks everyone. Thank you, Amber and Kate, for passing it off to us and for kind of setting the stage here today. I appreciate you all being here for what I assume is most of your lunch hour. We're glad to have you with us and hope that you're able to take something away from the work that we've done here in North Carolina. You can go to the next slide. This is just our disclaimer saying that these, this is our material and it's reflective of the work that we've done and is not a reflection of any of our funders or of the PTTC. Next slide. So we have three main objectives today. First, we want to help you understand the role of partnerships in developing and implementing a co-dispense project in the pharmacy setting. We really want to emphasize that collaboration between pharmacies, local prevention providers or coalitions, and other community stakeholders. We hope that you will learn strategies for braiding funding streams to support and sustain a co-dispense model. And we also want you to be able to apply actionable strategies from some of the examples that we learned in our pilot project that we ran. Before we move on from the objectives, if there's anything else that you would like to pull from today, if you want to drop it in the chat, we can make sure that we try to cover that. We will have time for questions at the end though, so just know that too. if you come up with something as we go, feel free to just either hold it to the end or throw it in the chat. We will be addressing questions. Next slide. I'm Jane. I am a grants manager at Community Impact NC, and I will let Holly introduce herself.
Hello, I'm Holly Carter. I'm also a grant manager and communication campaign director with Community Impact.
And just a little bit about Community Impact NC or SYNC. We are a statewide support agency. So we provide support to coalitions across the state of North Carolina who are working in the primary substance use prevention space. We do trainings, we do technical support, we help with strategic planning. We also talk about, different evidence-based and innovative practices that communities can do to really minimize and prevent harms caused by substance misuse, but mostly historically primary prevention efforts. Next slide. And I will turn it over to our awesome pharmacists to introduce themselves.
Good afternoon, everybody. My name is Devin. I'm a pharmacist with True Care Pharmacy in Concord, North Carolina. I'm currently in our second location here down the road, but so Concord is just a few minutes north of Charlotte, North Carolina.
Elizabeth, did you want to? I don't know.
Oh, sorry.
That's okay.
Hey, everybody. My name is Elizabeth Locklear, and I am the pharmacist and pharmacy owner of Rocky Point Pavilion Pharmacy. We are located southeastern North Carolina, so about 20 minutes west of Wilmington. So we're along the coast.
Okay, thank you.
Okay, thank you everyone for being here, and especially our pharmacists. They were gracious enough to join us at a couple different conferences and present about this program. And so this will be our first time presenting this virtually. Thank you all for joining us. So to give you all just a little bit of background on the project that we did, we completed this project, I believe, like summer of last year. So we had about 6 months to implement what we called an opioid safety co-dispense project with some local pharmacies across North Carolina. And we consider this a pilot project. So we have, we kept this on a smaller scale as far as just the design of the project and the evaluation of the project, and certainly hope to have the opportunity to expand on it a little more in the future. So as far as what we did have involved with this project, as Jane mentioned, our organization provides community support across North Carolina, that's statewide to all primary prevention providers. And so as part of our support, we administer multiple grants and the Lock Your Meds communication campaign, which includes some of those grants, as well as the campaign, include opioid misuse and overdose prevention strategies. And so as many of the community prevention providers that we provide support to, we're partnering with their local pharmacies, implementing select opioid safety and overdose strategies, prevention strategies. We recognized an opportunity for a more comprehensive approach that would be more intentional, that could also include some patient consultation and education, and also include policy. Because, of course, in prevention, we're always looking for that, those P's, those big P's and those little P's, the policies and procedures. We can move on to the next slide, please. If you guys a little more, a little better look at the objectives in that project. So having the knowledge of these great relationships that our community level providers had already with the pharmacist, we asked them if they wanted to facilitate a connection between our organization and their partnering pharmacies to participate in this project. And they all were on board. I believe we started this initially with, Jane, am I correct in saying six different communities, so 6 counties? Is that correct, Jane?
Yes, that's correct. So 6
Yeah.
communities and several had pharmacies in multiple locations.
Yes, thank you. So all 6 of our providers said yes, they would love to see if their local pharmacies wanted to be involved. And all 6 pharmacy partners said yes. And we consulted, we met with these pharmacists and included them in all of the design and all of our objectives. So we came to the conclusion that our objectives would be to co-dispense a disposal kit, a locking product. In most cases, it was a locking medication storage pouch and an opioid antagonist with every opioid prescription there at the point of sale in the pharmacy. And for participating pharmacies to adopt policies related to this project and the items included in the project and the data collection. So next slide, please. Thank you. So getting on to the program design, again, I want to reiterate that we consulted with the pharmacist in all this program design to lessen any burden on them and on their staff. And they all included their staff in these decisions in designing this program. So obviously from our point, our first step was to get that personal connection with the pharmacies. And again, we did that through our prevention providers that already had working relationships with them. So we didn't just randomly call upon pharmacies that had no idea who we were. And we did conduct those focus groups with the pharmacists and their staff. And then we're able to solidify those components of the program. We were able to determine the training needs for them as well as for their staff. We then developed a training toolkit so that, if they did have staff changes or had staff that weren't able to be on the training in real time, could refer back to that. And we developed our data collection form. We chose, rather than to go through a formal system, the systems that the pharmacies were already using would have been to go through the systems they're already using for their record keeping would, one, be costly on our end. And so we, as well as we determined would be a little bit more cumbersome on their end. So we were able to just develop something simple and easy. And we ended up just doing a basic Google form for them to enter their data monthly for us, for our reporting purposes. And we did that collectively with them. And then we also created an MOU between our agency and the pharmacy. Next slide, please. So again, the components, so the materials included in this opioid safety kit. And we chose that name intentional so that it would be less stigmatizing and less intimidating to patients, for them to understand that this was a safety kit in their home, not something needed because there was an issue in their home, as a lot of people provide feedback on certain items. So the pharmacists were clear that this was a safety kit. So that included, again, the opioid antagonist, an at-home disposal kit, a locking medicine pouch, And I did want to highlight the pouch was chosen upon recommendation by the pharmacist. You know, we asked them, would they rather have a hard locking box or the soft pouch for their patients? And the pouch was just a better product for them to be able to store. So just logistically to keep behind the counter ready to go in with the patient's safety kit.
Sorry, just to
Yeah.
add, it was also easier to put in a bag and patients to carry out. It wasn't as big or bulky or cumbersome, and it just fit nicely into a small bag.
Yeah, Devin's showing an example. Hold that a little closer in middle of the camera, your blur. There you go. He's showing his little pharmacy bags. He's able to put all three of those products in that bag. It's also featured here in the image on this slide, and give that to the patient along with their opioid prescription. So also training availability and indicators for dispensing. And we, across the board, just decided that every opioid prescription would get that product. That way it, was one of the intentions behind this is to change social norms and make opioid safety products just the norm in every home with all prescription medications. So by doing that, it's indicated for everyone who has that prescription. And then we developed the metrics for tracking, which have primarily, with that being a pilot stage, were mostly outputs. So how many were dispensed. And then we were fortunate with the funding we were able to secure with a community impact, a compensation stipend for the pharmacist for their time that they have taken to provide the patient consultations. Next slide, please. So here are, I want to remind everyone, this was just 6 months. Am I correct on that, Jane? Okay, 6-month time period. These were our metrics, our outputs that were collected. So the number of patients served were a little over 1,700. The opioid antagonists distributed were 1,200. So you can see majority of the patients took home the antagonist along with their prescription. Lock boxes, almost 1,400 dispensed. And the disposal kits, again, a little over 1,300. And the pharmacies, all 6, like Jane said, some of them had multiple locations. So there were more than 6 pharmacies that were just participating, but 6 ownerships. All 6 developed policies around the opioid safety kits. And so now we'll move on to some questions that we would, and talking points that we would love for the pharmacists to share with you all about their participation in this program. Next slide. So I will ask the first question, and we will let Elizabeth and Devin share their information on this. So we'll start with you, Elizabeth. What was your motivation to participate in this project?
So when I was presented with the opportunity to present in the project, I thought it was really cool, just a co-dispense model. It got me to think about my current pharmacy practices, and I've been a pharmacist for over 20 years, and I've seen a lot of things change. Lots of stuff has changed around opioid dispensing, and as a healthcare provider, I recognize that I have a role to assess my responsibilities with the opioid epidemic and the ways that I can help as a pharmacist to make my community safer. And I started looking at my current co-dispensing or lack thereof, because in North Carolina, I can give a Narcan prescription to anyone that walks in the door, but were we doing it? And what I was able to see was we weren't. And so this project aligned perfectly with an area where I wasn't serving my community to the fullest. And so that was part of my drive to implement this and get this going in my pharmacy, because I saw an area where I wasn't serving my community to the best that I could. And this provided an avenue for that.
Fabulous. Thank you so much. Elizabeth knows she just touched our heart with that information. So love her compassion that she has for her community. So Devin, how about you? What motivated you to participate?
So I have not been doing it quite as long as Elizabeth has. I'm about 5 years in, but I can definitely resonate with her approach of saying, want to do more. So basically, up until, still to this point, when dispensing opioid medications, there's a corresponding responsibility just to look at appropriateness of therapy and safety of the therapy for the patients. Now, obviously, there's a lot of information and things like that of basically while we're all here, discussing why or how do we move forward. And I think that this project was one of those key indicators for me that was like, well, this is just the right direction to move in from a profession standpoint. And Kate's presentation earlier, I think that she really highlighted a lot of really, really, really high level, barriers to dispensing all of the harm reduction measures in pharmacies, as well as highlighting the effectiveness of what we can potentially do. And I just want to corroborate every single bullet point that she said. Not just, these aren't just, aggregated data, not a big deal, or, you kind of get into these really big population health discussion points, but every single one, I was like, yes, yes, yes. Like, it's very, very, head nod worthy, if you will. So, but, basically, so there were, out of the project, 1,705 dispensations our patients helped or counseled. My primary reason I wanted to get involved in it is because I wanted to help to have a cultural shift in how we look at dispensing these medications. Obviously, when you bring up a cultural shift, obviously that's like, okay, it's very resource intensive to do that. So you have to ask yourself, well, is it worth doing, or is it worth having a conversation? And I think the second you start to peel back these layers in these conversations, it quickly becomes apparent that yes, it is worthwhile to do this and then have this cultural shift. So 1,705 conversations around harm reduction occurred in 6 months in 6 pharmacies. If we can do that in 6 pharmacies for 1,705 dispensations, probably some duplicate patients in there, but just raising the level of awareness of the service nationally, replicating this model would be just immeasurable, and the amount of impact it could have, and the number of lives saved. You can't even begin to imagine how positive it could be. So I believe some of the other points I'll talk about are covered in some of the other questions. So I will save it.
Thank you, Devin. Next slide, please. Can you share what has been successful and especially kind of highlight any positive reactions or experiences that you've had with patients as a result of this project? Sorry, Elizabeth, I'll let you go first again.
Okay. So I had nothing but positive responses from my patients. But as far as, my success story, I mentioned earlier that I looked at my lack thereof co-dispensing prior to the project, and I looked at 6 months of data before the project and my pharmacy software system to see how many Narcan I had co-dispensed 6 months prior to starting the project, and I believe it was 5 or less. Then I took my data in the project, so the 6 months after the project, and I dispensed more than 100 Narcan. So 6 months prior to the project, less than 5 probably Narcan, and then after the project 100. So I was able to really turn around and start actually co-dispensing, which is what I should have been doing all along. But there are barriers, which we'll talk about later. But as far as like with my patients, I had patients that they now got Narcan and they would tell me, oh gosh, thank you. My doctor has told me that they want me to have Narcan, but I haven't been able to afford it. So this really took away one of my main barriers, because we are in a rural community, and cost plays a huge factor. And has it was discussed earlier, if someone doesn't have insurance, it's around $50, and that's just out of a lot of my patients' price range. And then I would say the next most impactful uh, thing that I think came out of the project at my pharmacy was the ability to not only educate my patients, but the ability to educate my staff. Because what I found is I'm one voice, but when I educate my staff, my one voice is amplified through them. So because when patients come in, yes, I speak to them, but the majority of the contacts are going to be from my cashiers, from my technicians. They all have touch points with these patients. And I find that when my staff is well educated to the different services that we're providing, that my patients get better served, because they're not just they're hearing my voice amplified. So just the education piece to my staff, which flows on to my patients community, was that was huge for us.
Thank you.
Yeah, if I could just quickly, since Elizabeth spoke about her staff being trained and how important that is, highlighting that they are the touch point to the patient, not typically the pharmacist. I just wanted to highlight that in our program design, the pharmacists stressed how important it was that we did include their staff. And so if you all are reach the point where you want to start a program similar to this, please note that their staff is very important to them, and a very important part of the work that they do. And so always to include them and be respectful to their staff as well.
And I was actually going to build on that too. So yeah, I think for, what was successful in our program, just opening up the conversations, not just with the patients, but also with the staff, and just hearing how the opioid epidemic, and then just really just dispensing high risk medications in general has affected team members, and seeing how important it is to certain team members, because then all of a sudden it's not just a concept or a theory, it's something that actually means something to patients and to staff alike. I think we used a fair amount of different, counseling strategies. I think a very common one that was successful for us is just to describe it as an as needed, so if you had a patient that, this isn't even in a healthcare setting, but if someone says, I'm deathly allergic to bee stings, one of the natural questions to follow that is, do you carry an EpiPen? So why don't we do the same thing for high dose opioids? So that was the kind of level of, it's obvious when you ask it and framed in certain ways to patients. We kind of took that approach to it. And they were, now I can, I'll also, mirror what Elizabeth was saying. The number of negative responses we got from patients, I could probably count on 2 fingers if that was the case out of all the ones that we did. So, it was largely just very much appreciated. We kept our documentation. Now it was very, what we submitted to the Google form to the sync team was very quantitative data. To empower our other pharmacists and team members, we also left just a box there to just write down how the encounter went, just so we kind of circle back. And we in our pharmacy, so it was really successful with the sync team, is allowing us to use our individual workflows and kind of let our creativity and the team shine through. We got the team to say, well, how do you want to work this in workflow? How do you identify who's gotten one, who hasn't gotten one, and how do you want to trigger it? Really workflow orienting these things, because ultimately that's how these things get executed sustainably. So we would actually take this form, which was basically what would be the standing order form for North Carolina, and then we appended a little section there where the pharmacist could write notes, and we just scanned that in as our hard copy prescription once it was dispensed. So we have all of that documentation provided for every encounter. So it was really neat to go back and look at all of what was written down on those encounters. Another thing that was really, honestly, really successful too was, when we did the lock bags too, I really tried not to just throw it in there and say, hey, there's a bag in there if you want to use it. If they showed any interest at all, I'd cut this thing off and set the code with them there at the register or wherever I was encountering with them, and then we'd set the code together, their code, and then honestly, I'd throw their bottle in there and lock it and give it back to them and see if they could open it. So they were already, used to putting it in there, and then before they walked away, it was still in the bag, so they had to use it. And so talking about, behavioral change, that was one of the things that helped to kind of guide that, and following up and say, are you still using it? We had pretty good follow-up for that. So
Okay, I'm gonna go off script just a touch. Okay, so bear with me, but I think that speaking of workflow and really integrating this in a way that made sense for your current workflow, I think many of our pharmacies developed as part of their policy like a flagging system, so that with an opioid prescription it automatically flagged for the pharmacist to have that patient consultation time. And so I was wondering if you could kind of walk me through I'll let each of you do it, but kind of walk me through what that looked like, and like the conversation that you would have with your patients, because I think that could be helpful for the audience to hear, like, because one of the great things that came out of this that we weren't really expecting or anticipating was that really solid patient connection, and really having an educational conversation around opioid safety, and why they're receiving these things, and like Devin was saying, how to use the materials that they were being offered and provided. So just just real briefly, like, how did you have those conversations, and did you have them with every person that received a prescription? Whichever one of you wants to go first.
I'll go first. So the way we integrated it into our workflow at the pharmacy, I had a member of my staff put together the pharmacy safety kit. So we had a bag, and then they put the Narcan and the lockbox and the disposal kit in there. And then I actually I typed up a short little statement that basically stated what was in the bag, stated our relationship with CINC and what the purpose of the bag was, because I have found that you have conversations with patients, and they you have a 5-minute long conversation and they might remember 30 seconds of what you said. So I found that having that little statement, if they went home and read it and had questions, sometimes they would call back and say, hey, what is this project that you're doing? And so we could talk about, why we were doing this, why was it important. But so in my pharmacy software system, we built triggers, is what we call them, to identify basically when we were filling a prescription, which obviously, when you're doing an opioid prescription, but we built triggers around different MMEs and flagging MMEs that exceeded 90, that exceeded 50, just to kind of, if anything, kind of point it out to my staff. So because I can quickly calculate an MME in my head, but my staff might not know how to do that. But it flagged them to let them know, hey, this is a high MME prescription that we're filling. Go grab a safety kit. So my staff would automatically, by the time the opioid got to me to check, it was already with the safety kit. So that way it went to my point of sale with the safety kit. And then my cashiers knew if the patient is getting a safety kit, they're having a conversation with me. So that was kind of the way we worked it all in. And it opened the eyes to my staff as well. They're like, gosh, I didn't realize, we had, this was a high opioid prescription. I'm like, yeah, it is. So it kind of brought awareness to them, as to, this is in our community. This is here. This is why we're doing this. But yeah, so that was how we kind of worked it in.
Perfect. Thank you.
Yeah, and that's a perfect example of a policy and how we, that we at Sync did not create those policies. We wanted the individual pharmacies to create their own policies so that they could create a design that would work in their current flow.
I feel like Elizabeth probably uses Pioneer based on that response. So yes, we use the same system as well. So Pioneer RX, it's a pretty common independent pharmacy system. So the idea of triggers and care goals and things like that is sometimes it can be reserved for a little bit more advanced users, but there's a significant amount of customer support available for Pioneer to be able to implement that even globally. But as for us, we did do a pretty customized route. We didn't actually go the trigger route that Elizabeth described. We went a little more open-ended. As I mentioned, I was pretty keen on just trying to witness the cultural change. So we tried to send it back. Hey, it looks like this one would be a good opportunity for one. The MMEs is a great example. Other medications that go along with the that would result in high risk combinations of medications and increasing risk for overdose. So we would bring that back and have a technician do it. So we would I don't want to get too technical in it, but basically we would log in our system as a compound. So we didn't require multiple data entry points for each item that was given to the patient. We made a compound, which is multiple ingredients. It's a way of tracking it. So we would basically make a template. So you can do a template RX in Pioneer. And basically, so we generally would go the, you get all three route, unless they said they didn't want one, then we change it later. So we get all three, and it would be a compound prescription for that. And so we would kind of send it down. It started off with us having to bring it back to the technician, but to the point of cultural change, by the end of it, it really felt like that very trigger-like looking mentality. If I see the script, and it was kind of like this cultural trigger, and it was very uncommon for us to get a new opioid script and not have the compound alongside of it. So it essentially, the earlier in the upstream we can trigger that process, the better. And so basically by the time it would hit the register, it was automated, if you will, that we would have manufactured an encounter with the patient.
Great. Thank you. Next slide, please.
Okay, now on to what are some of the challenges and barriers that you all faced. And I think Devin already shared one barrier. I guess it's more of a barrier for patients. A lot of folks don't want to use their lockbox because they have to take the time. I would be guilty of this too. Take the time to, figure out how to set the darn thing and how to work it. And the fact that they went ahead and took care of that really only takes a minute, but sometimes to some of us, those things just seem like too much, too cumbersome or time consuming, and that he would go ahead and just have that set for the patients. Like, here, it's ready for you to use. It's already personalized, ready to go. I love, love, love that. So, Elizabeth, what are any barriers or challenges that you faced with the program in general?
Well, one of the challenges, and I guess the project really overcame that challenge. I you mentioned it earlier, was the cost associated with some of the like the Narcan per se, because cash price roughly $50. And then I would say the majority of the time when I tried to run someone's insurance for one, it either the product wasn't covered, which I think is a huge obstacle that needs to be addressed. My personal belief is that every insurance company should cover at no cost to the patient a Narcan, but that's just my personal belief. But 9 times out of 10, if it did go through, it was a $47 copay for the patient. Again, that was way too much for some of my patients to afford. So being able to provide these products at no cost to my patients was huge. And then not only that, there's also PBM reimbursement to the pharmacy. There were times where I dispensed Narcan and I dispensed it below my cost to bring it in the door. So here I'm providing a service to my patient, to my community, and I'm losing money doing it. I do it all day long, unfortunately, but that's a barrier. And I'm sure there are some, in pharmacies that can't afford to take the hit. So that's another thing that I think needs to be addressed. But I really do like how Devin said that he showed his patients how to open set the code on the lockbox. I didn't think to do that. That's really cool. One thing that I thought was really cool, though, was I had one of my patients that we were giving one of the safety kits to, and I was I say elderly woman, she an older woman, and she was picking up her prescription, and she said to me, she said, well, gosh, it's just me at the house. I don't need a lockbox, or I don't need I don't need a Narcan. And she was there with her granddaughter, and I asked her, I said, does your granddaughter come to your house? And she said, well, yeah, every day after school. I said, well, it's not just you at the house. You don't want her to accidentally get into it, or you don't want your granddaughter to accidentally, get exposed to it. So that we have these safety measures in place, and we have them in place because you don't want things to happen. So that was kind of a cool conversation to have with her.
Great, thank you. And Elizabeth did highlight this, and I apologize, but I'm not sure I made that clear in my explanation of this program design, but we were able, with the funding that we secured for this project, we were able to provide all of these products at no cost to the pharmacy or to the patients. So they are giving these products to their patients for free. And I see that someone in the chat had highlighted that and takes that from a transaction between the pharmacist, a monetary transaction, takes it more to a level of just concerned that I care about you and care about our community and want to do what we can for their safety. So, we acknowledge that these products are not always freely available to us, but Jane's going to talk a little more about funding and how that you might be able to support some of this in your community. So Devin, would you please share with us some of the challenges that you all faced?
Sure. Yeah, and I mean, I think that the cost barrier is always going to be there, but it's just kind of show you what happens if you can overcome that cost barrier systematically. This is kind of on the other side of that. Yeah, those copays can be pretty pricey. We did tend to kind of filter through to see like who was eligible for us to kind of triage some of our products to go free versus does your insurance already cover it at $0 copay. So we're trying to be fiscally responsible with that, with the dollars and the products and the resources given to us. I think that the biggest thing, the hardest challenge here is overcoming the inertia of new product or new initiatives and trying to have, to influence a cultural change requires an amount of persistence, I think, that not everybody's ready for. And you feel it. And you have to believe in it, to let it kind of go through a couple of inertia cycles inside of your own local environment, to then let that push through, and then you'll kind of see these a little bit of a bigger inertia cycle. Okay, well, we put forth the effort, it didn't quite work. I think everybody on this, every participant on this call has experienced this within their respective organizations, and it can be really tiring. But I think that removing these biggest barriers helps us to maintain that forward progress, and to really try to impact that change. Oh, sorry, community impact that change. So, yeah, that's all I've got for that one.
Great. Thank you. Next slide, please. And now I'm sure the question that everybody's anxious to know the answer to, how are you sustaining your efforts since funding for the project ended? And how have you and your coalition or your prevention partner partnered in these sustainability efforts? Elizabeth, I'll give it to you first.
Yeah, so for my pharmacy, like I said, we built in the triggers in our pharmacy software system to alert my technicians at order entry when the prescription was coming through that would qualify for a safety kit, and which now that we have exhausted all of our free safety kits, it does put the cost barrier back in place. However, through connections through this project, so I already work with my county's substance use prevention program, and so it honestly built stronger connections with them so that I could reach out to them and say, hey, I'm out of lock boxes, do you guys have any? And so they send me lock boxes. Hey, I'm out of disposal kits, do you guys have? And so I've through my connections that I got through the project, I've been able to find other avenues to get free products for my patients. And so that's been great. I pretty much keep lock boxes up at my front counter to anybody that wants them, because I've been able, from our Pender County substance use program, to have those coming into the pharmacy to give to anyone that wants them for any reason. So for me, that's been a huge win from this project, or just the connections that I've made at the local level, state level, just everyone, because the more connections you have, the more the right people to ask the right questions to, and the right resources to get them to your community.
Great. Perfect. Thank you. Devin?
I will mirror that same strategy. We do work with our local health department, Cabarrus Health Alliance, to help source some of those Narcan products. We do still have some leftover Deterra and bags. I think so we've had to request some more Narcan to come in, but we do still have some leftover from the Sync project. So I'll have to kind of cross that bridge when we get there as far as what we'll necessarily do, but I'm sure we'll figure it out for what to do as far as the bag and Deterra goes. We do have a disposal unit in the pharmacy as well, a disposal box. But as Kate mentioned, that is a cost incurred to maintain that box as well. We just reach out as also, it's not even just getting the product and becoming a repository for them, or just a dispensing point for them to help distribute it to the community. It's enabled us to continue in different substance use initiatives that they have done, different coalitions that have been operating outside of the health department as well, just to help kind of keep tabs on what is the county engaging in with the different community partners that are outside of just us, so we know we're not just operating in a vacuum, to see how are we collectively tackling this effort as a community.
Awesome. Thank you. So again, I want to thank our pharmacists for taking the time to be here today and talk to you guys. And please don't worry, they are going to hang out through the end of the presentation to be able to answer any questions that y'all may have in a little bit. And now that we have kind of shared our pilot project, what components went into that, kind of how we started that up, and have let you hear the experiences of some of the participating pharmacies. Absolutely nothing wrong with a humble brag. We love a humble brag. We love the work that we've done in North Carolina, but we do want you to be able to walk away with just kind of like step by step, how can we do this in our community if we feel like we're at the point to take it to that next level. So Amber or Angelica, if you'll go to the next slide, please, that would be great. Of course, we cannot have a prevention webinar without throwing the SPIF model up there. So you're welcome for that. There's your daily dose of the SPIF model. So, but just to kind of break it down for you, of course, we started with assessment. We realized that, hey, some of our coalitions are partnering with their pharmacies to put out medication storage kits, medication disposal kits. A lot of our coalitions were working on other disposal initiatives, whether that's take back events, whether that is some of the permanent disposal boxes, as Devin referenced. So our coalitions were already doing some of this work. And then we realized that a lot of our coalitions, and I don't know how it is in other states, but at least in North Carolina, a lot of our prevention coalitions were being leaned on as the experts in substance use prevention. And so a lot of them were then being asked about doing harm reduction things. And so we just saw a really great opportunity to, as Holly mentioned, kind of streamline and create a really comprehensive practice around this. And so when we were thinking about the communities that might be in the best spot to pilot this project, we looked at not only what coalitions already had those existing partnerships with their local pharmacies, But we also looked at counties that had higher than average rates of opioids dispensed per person. How many communities have locally owned or independent pharmacies? Are the pharmacies already involved in prevention or harm reduction efforts? So for those of you who are coalitions or prevention providers, like those were some of the things that we thought about and looked at. If you are with a pharmacy or with a health department or something like that, and you're interested in starting something like this, I would encourage you to similarly look, is there a local coalition or local prevention providers that you can partner with on this initiative? How can you integrate this type of work into your current workflow, into your current reporting systems? Some things that we assessed when we were first starting out and we were trying to determine what resources we would need for this project. We asked all of the pharmacies that were participating, how many opioids on average did you dispense per month in the last 6 months? And that kind of gave us a baseline for how many components of the opioid safety kits we needed to order. How many lot bags did we need? How many disposal kits did we need? How many Narcan kits did we need? We also looked at, of those prescriptions that you dispensed, how many of those were initial opioid prescriptions? This person is getting an opioid for the very first time. And so we also use that information in determining how much material to order. Would also encourage you to look at, what funding do you already have to support this work? What funding do you already have? What funding might be available in your community? What resources do you already have? When we're looking at capacity, I would of course encourage, like in this, the partnerships were really a key part. As you just heard from both Elizabeth and Devin, they have really leaned on those partnerships to sustain this work following like the ending of the funded project. And so looking at what partnerships do you need to build? Are you starting completely from scratch, or do you just need to enhance and expand upon an existing relationship? With this project, like partners are really going to help establish buy-in. They're going to help ensure consistent messaging across like systems. And so I would really encourage not just like a coalition prevention provider pharmacy relationship, but like working with your health department, reaching out to local harm reduction organizations, reaching out to your local opioid settlement coordinator, because all of these people and all of these partners can work together to bring in different components for this project. Another thing that we looked at when we were determining what products we were going to use, I know Holly's already talked extensively about how we landed on the locking bags. I would like to talk a little bit about why we chose both the Datera and the nasal Narcan. So for the Datera, we went with the Datera small bags, which hold roughly 15 to 30, I believe. We went with those, one, it being mainly a size thing for storage and for, dispensing something that would fit in the same bag as everything else. The Narcan, I know that nasal Narcan any nasal product is much more expensive than the IM products. However, when you're dispensing these safety kits in a pharmacy to people who are not healthcare providers, mostly, like these are general public people. So really not healthcare providers. Most of them are not injection drug users. The comfort level with IM naloxone, we did not feel like was there. We felt like it would be much less Stigmatizing, it created better opportunities to create this culture shift, as Devin was talking about. If we did the nasal product, it's just a little bit more, we felt like a little bit more user friendly. People felt a little bit more comfortable with that than if we were like, here's a vial and a syringe and this is how you use that. So yes, it is more expensive, but I think the response has been much more positive than if we had tried to go with an IM product. So also something to consider as you're thinking about what resources you have and trying to build out your project. So again, what resources do you already have within your own organization? What resources exist within your community? As our pharmacists have mentioned, you know, our prevention providers and our coalitions a lot of times have state level like block grant funding. Some of them have SAMHSA discretionary grants, DFC grants. Some of them receive opioid settlement funds. So they have the funding to be able to provide lockboxes and Viterra kits. We also have a lot of our communities have harm reduction organizations that are willing to partner with some of the naloxone needs. And we have, you know, there are organizations that have discretionary funds or opioid settlement funds that you can purchase Narcan with. So, you know, just take a good look at what's already there and how you can work together to implement this project. I would also look at how much you think you'll need to operate the project. And again, a good way that we assessed that and kind of determined initial needs was just asking, like, in the past 6 months, on average, how many opioids did you dispense per month? And that kind of helped give us that target number to start with. And then what funding and resources are needed to fill in those gaps, and where might we find some of that funding? For planning, so this often includes this project includes, you know, obviously offering naloxone and other tools when certain risk factors are present. And so as Elizabeth was talking about, like those higher opioid dosages, medications with a higher MME, if someone has an opioid prescription and a benzodiazepine prescription, you know, something that would increase that overdose potential or accidental poisoning potential. So those are things that we looked at and considered when we were trying to develop our policies around the dispensing. We initially talked about, like, do we want to assess risk? Do we want to, you know, develop a risk factor tool that the pharmacists kind of talk through and then decide if they want to give naloxone or not? And for us, it was just important to create this cultural shift to destigmatize naloxone in our communities. We felt like that would be helpful, not just for people with opioid prescriptions, but that would also be helpful for people who use drugs. You know, if we can normalize naloxone and start having these conversations and educating people in our communities, like, it's going to create a culture shift across the community. And so it was just important for us to distribute naloxone to everyone receiving an initial opioid prescription. Another thing that you might need to consider in your planning stage, depending on what state you're in, is if you have a statewide standing order or any sort of standing order that will allow you to dispense naloxone without a prescription. You know, again, for us in North Carolina, we do have that statewide standing order, but I know that I don't think all states have that. So most health departments do, so you can check with your health department. Sometimes they're willing to kind of create an MOU with you for that, but that's a consideration. Again, you've heard this from the pharmacist. I'm going to say it another time. Training pharmacy staff is essential. It was a really critical piece of this project. Doesn't need to be lengthy, like just a a brief training or even a brief conversation can equip the technicians and the other pharmacy staff with the confidence to discuss overdose risk, to provide key safety messages, and to I think if you can connect with them and find a way to make it important to them, like they're willing to share this message and echo this voice. They sometimes just need a few more tools in their belt to be able to do that. So I'm providing that training for the pharmacy staff. And the like number one best thing that came out of this pilot project for us was that patient education piece, and really focusing on safe use, safe storage, and safe disposal of medications, and the benefit of having these tools just in case you need them. It's better to have them and not need them to need them and not have them.
And we're happy to share the training toolkit that we used, for an example, or you guys are welcome to use anything out of it that would fit with a program that you're using or with your community, or with your state. Ours, was of course some areas personalized to this specific project, but to give you guys an idea, we're more than happy to share that. We're also happy to share the MOU that we used, if you guys want to utilize that or use it as an example.
Yeah.
So,
and just to share a story from one of our pharmacists that wasn't able to be on this call today, but that patient education piece can also allow them to respond to maybe overdoses that are related to illicit substance use. One pharmacist shared with us that she had a patient come in and get an opioid prescription. She provided the naloxone. She, told them how to recognize signs of an overdose, how to use the naloxone. And then later on, that patient's brother, who had a substance use disorder, overdosed. And because of the naloxone she got from the pharmacy and because of the education she got at the pharmacy, she was able to recognize the fact that her brother was overdosing and administer the naloxone successfully. And he survived that experience. But she said that she would not otherwise have had naloxone, or known that what was happening to him was an overdose event. So a lot of really great things have come from this, and that patient education piece is just is so critical. It's a critical component of this project. We did create MOUs for each of our partners. I think we have included those in the materials for the PTTC to send out to you all following this presentation so that you can kind of see what we included in ours. But it was pretty simple and straightforward. So of course, after all of that, you've created your policies, trained your pharmacy staff, you've developed your educational materials and your tracking tools, you've done your MOUs, you can begin project implementation. We had most of our pharmacies that had multiple locations. I mean, they said, if we're going to do this, we're going to do this in all of our locations. We kind of talked about, well, why don't you just start with one and see how it goes? And they were pretty committed that if they were going to do it, they were going to do it. So, a very go big or go home mindset for our pharmacists. So, I know that everybody's capacity will be different, and that'll be something that for you to talk through and decide on. But I would do as much as you can with what you have. Always want to track and share impact. I think that just sharing the impact of this project has created some opportunities for sustainability, and different small ways to sustain the project. And then, of course, consider sustainability and ways to reach areas and populations of high need from the beginning and throughout the process. Another thing, I'm just going to highlight Devon for a second. They as they got into this project, they decided to also distribute Narcan automatically to anybody coming in to purchase syringes. Just think about different ways to reach people who might be at higher risk of overdose. Just because they're not picking up an opioid prescription certainly does not mean that they're not at risk for an overdose. And so just kind of thinking about that as you build this out. So that was something that we didn't think of initially, but was a great idea that Devin and his team came up with.
Can I just pop another
Yeah.
little point in there? Just in the conversations that come out, we have a significant amount of folks that wound up being like in Narcotics Anonymous or Alcoholics Anonymous. Just mentioning and spreading that news or that information into those groups and those communities, I think drove a fair amount of inquiries and phone calls that, those calls came in, and it was directly routed, usually me when I was there, but got it kind of into the right hands.
Yeah. Thank you. And then Amber, next slide, please. Okay, so finally, how can we braid funding and initiatives to support this work? So, and what is really the importance of braiding funding? And I do want to point out that when we talk about braided funding, we're talking about really taking different funding streams and kind of weaving together different aspects of that to create a comprehensive project. Of course, when you're braiding funding, you've got to make sure that any reporting requirements, any funding restrictions for each funding stream are maintained. And you'll also want to make sure that you're not totally duplicating efforts. I have a whole presentation on that. If you have questions, feel free to connect with me. I'm happy to kind of help talk through some of those things. But for us, braiding funding was an important aspect of this project. It allowed us to really maximize our resources. It encouraged more collaboration and involvement across a diverse group of stakeholders. It has increased the overall impact of our project. We had several pharmacies reach out and say, hey, so-and-so came in and they're getting a non-opioid prescription, but they'd still really like a locking device for this prescription. Can we give them one? And, unfortunately with this funding, no, but your coalition or prevention provider probably has boxes that they can give you that you can give to non-opioid patients who want a box. So I think Elizabeth mentioned that, now they have them just kind of available to anybody who wants one because of that partnership. It allows us to support a comprehensive strategy, as we've talked about, and then will help sustain programs over time. So this pilot project, this initial project, was funded through the North Carolina American Rescue Plan Act Temporary Savings Fund. North Carolina has a savings fund for this, and so this project was implemented using dividends earned from that fund. So it was very time specific and has since ended. But we also supported this funding through state block grant funds. Of course, you cannot use those to purchase naloxone, but our coalitions again are using state block grant funds to provide locking pouches, to provide disposal kits. We have several of our communities have the SAMHSA discretionary PDO grant. So they have been able to use their PDO funding to purchase naloxone and support the naloxone, the continuation of providing naloxone for this project. Other examples, though, are DFC, PFS, opioid settlement funds. If you have any like unrestricted community donations, foundation grants. Like those are really great ways to sustain something like this. And all of our pharmacies that we identified for this were independent pharmacies. So we have not worked with like a Walgreens, CVS, any of those more chain pharmacies, just because those processes usually take a little bit longer. So not saying that that's not possible if you don't have a locally owned pharmacy in your area. It's just there's a little bit more red tape. They've got to go go up the chain of command, whereas you just don't have that barrier with your locally owned pharmacies. I mean, as you can see, Devin is literally sitting in the pharmacy working. Elizabeth owns her pharmacy and works there when she's not home with her sick babies. So, you know, the person that you need to talk to, the person that can give you permission to do the project is usually in the pharmacy, which makes it a whole lot easier. And a little bit quicker to get that going.